Okay, so now I'm going to go over 7 signs in 7-year-olds. So this little section is to help you identify and to help you look for things that are really important in order to refer them for orthodontic treatment, for phase 1 treatment, okay? So the role of the dental auxiliary, of us, the hygienists, the dentists, the staff, actually we're to recognize the potential for malocclusions. We want to do early diagnosis. We want to explain the possible interceptive treatment. And we really, really want to educate our patients and our parents, okay? So our doctors depend on us to educate our patients in order for them to help them. And it's great to be part of that team. So I'm going to try and help you figure out what to look for your early diagnosis, okay? So here's a whole bunch of cute little kids. Kids are fun, most of them. Some of them you kind of want to, well, we won't go there. But early screening, again, you want to detect. You may prevent maxillary mandibular crowding. You may help stop oral habits. So form follows function, remember. So a thumb sucker after so many years, you're going to have a malformed palate, okay? You want to address any cross bites, any anterior open bites, any really deep overbites, any jaw discrepancies, retrognathic, prognathic, and any airway problems. So all this early screening may detect any of that. That's a lot of things to look at, right? Well, it's not really a lot, but I don't mean it in that sense. I mean it as in there's so many things that you can do to help your patients at this age. It's amazing. So again, if you want to like take a picture of this and post it in your operatory and stick it on your wall where you're working every day and kind of remind yourself as to what to look for, it's a great idea. Okay, so our goal is early diagnosis. So we want to not extract any permanent teeth, and we want their jaws to be aligned properly. Again, I can only speak from experience, but when you have 4 bicuspid extraction and versus non-extraction, the difference in appearance is amazing, okay? So when I first started working for Dr. Rondo 20-some years ago, I went to a course he sent me to, and it was an orthodontist, not a general dentist, that was teaching the course. And he showed us, I forget how it went, but there was twin brothers, and he was showing us the case, extraction versus non-extraction. And the 2 brothers were like, wow. Gorgeous, not so much. And I don't mean to say that negatively, but it really makes a difference. I want you to realize that non-extraction is definitely by far, in my opinion, and what Dr. Rondo's been trying to teach for several decades, it does not give you the best outcome. So more and more orthodontists and everywhere all over the world. I mean, we were kind of old in Ontario, kind of started out, like Dr. Rondo, some of his bestest friends are orthodontists in the United States and Europe and everywhere. He worked with them 30 years ago, and here everybody thought we were crazy. But anyways, it's finally done its first full circle, and I mean, Dr. Rondo's worked hard, and he's gotten more and more people to look at this point of view. It's not about him, it's not about you, it's about helping children. Okay, so there's one of my tangents again. So our goal is to try and do non-extraction. And the other thing is a lot of our extraction cases are TMJ patients. They come in with jaw pain, and they've had extractions. I know this sounds crazy, but we've done this. I've seen it a couple times, not often, where we've actually expanded an arch enough and moved molars back enough in a TMJ patient and put fake teeth back in. So what does that tell you? Okay, so they had gaps. So sometimes they extract teeth, you end up with this gap that never closes, but it wasn't that big enough for a tooth, so we made it big enough for a tooth all those years later, and then alleviated the TMJ problems at the same time. Why? Because it wasn't like everything was shoved back. Remember the jaw, you don't want the condyle to be pushing against all those nerves and blood vessels, or you're gonna have TMJ problems, okay? Anyway, so remember, form follows function. There's my lovely 2-year-old, 1-year-old, whatever she was back then, sucking on 3 fingers, pulling her lower jaw forward. So potential results of non-treatment. So if you don't treat early, these are the things that can happen and will happen, okay, depending on the patient. So you could end up with severe crowding in the permanent dentition, which can cause periodontal problems. We know that. We know that teeth that are crowded, rotated, how do they clean well? How do they floss properly? You're going to look for, if you don't treat early, anterior, posterior jaw discrepancies. So a retrognathic mandible is a lot easier to move forward in a 12-year-old than it is in a 32-year-old. We still do it, but it's a little bit different, okay? Diastemas, bruxing and clenching when they have really deep overbites, when the mandible's far back. A lot of times the jaw wants to come forward, your airway wants to be opened, your body wants you to breathe. So your jaw, usually it's an indication that you're grinding, you're clenching, you're grinding your jaws around in order to help yourself breathe. So this especially happens at night. Your spouse or someone may tell you that you're making noises at night, and that could be an indication that your jaw's not happy, it wants out. Okay, so, and all this stuff can lead to temporomandibular issues and airway problems. We want to make sure they have a nice airway to breathe if we can help them, okay? So what are we gonna look for? Non-treatment equals neglect, in our opinion. If you don't do anything, what are you doing? You're monitoring nothing. Come back in 6 months. Come back in 6 months. Well, you're doing nothing. So it could potentially lead to a lot of problems. You can have crazy wear on the teeth, crazy crowding on the teeth, okay? So we want to intercept. We want to intercept orthodontically, orthopedically, especially in the 5 to 12-year range. Treatment can greatly benefit the patient's entire well-being and make for a happy patient. Read some of our Google reviews and you'll see what I'm talking about. Parents absolutely are thrilled. I mean, I'd be thrilled too if I was a mom, which I am, but of what you can do for a child and how you can change their whole life, not just their appearance, but their whole life, okay? So early screening can and corrective treatment can make a difference. Functional orthopedic appliances. So early treatment can avoid this. So she was so crowded. I mean, if I'm looking at this mouth right now thinking, okay, maybe if we would have expanded when she was 8 and we gave her a little sectional, she wouldn't be walking around like this till she's 16, right? So this is her. We actually ended up, I just jumping the gun. She had a hyrax, we expanded. Remember I mentioned we cut the mesial rests off the 4s, or the first bicuspids. That's just showing you then. We had braces on at the same time as her expander. This is actually a Mara appliance, but just to show you where we started, where we almost finished. Okay, and again, this is saying could have avoided treatment in high school. High school is a lot harder to deal with this stuff when you're a teenager than you are between 5 and 12. Most kids don't care. Teenagers are all about their looks, right? So this case is just showing you a straight wire with a Mara appliance. And okay. So here is Laura, and her chief complaint is headaches. This is odd because children should not have headaches. We actually treated her mother for headaches and TMJ and straight wire. So usually in our office, if they come in as a TMJ patient, they finish as an ortho patient. Basically, they come in for TMJ, Dr. Rondo will adjust their bite and put them in an orthotic, and an appliance that will hold their jaw where they're out of pain, they're out of clicking. Then after stability in 4 to 6 months, I'm just trying to explain this in a nutshell, they come over to the ortho department and Dr. Rondo cuts the splint away slowly. So upper braces, cut the splint off the lower second molars, bring them up. Cut the splint more off the first molars, put a bracket on them, bring them up. Straight wire across the top, elastics to bring up the second molar, elastics to bring up the first molar. Basically, and the splint, the splint is still in there. So that's what's holding them there. Then we say goodbye to the splint, but their jaw is still in that position. Remember, he brought their jaw forward, he opened up their bite. It's a splint in the TMJ land, I call it. And then we finish with braces, because what we're doing is we're bringing the teeth together in that forward, comfortable, thank you so much for helping me get rid of my pain position. That's TMJ in a nutshell. Okay, so anyways, where I was going with this is headaches are they shouldn't be, kids shouldn't have headaches, okay? So unless they're having a sinus cold or something, it's not typical for them to have headaches. It's usually another cause. And this mother came in with a whole bunch of headaches, like her main chief complaint was headaches. So when you have a parent that has headaches, because we asked that in our TMJ questionnaire, is there a history of jaw problems or headaches in your family? Well, if a 10-year-old girl says yes, my mom or my aunt or my grandma, then you kind of go, oh, and you say, okay, well, we got to make sure we want to prevent that. And it happens so much in our office when we go from one family member to the next that you don't want to, if your parents have headaches or your dad's like this, then you're most likely, there's more chances of you being like that or you getting headaches. So let's try to intercept that and not let that happen. So Laura has narrow maxillary arch and she's got some flared incisors. Here's her ceph, here's her pan. Remember, you have to do the pan, you have to do the ceph, you have to do the chart. She's got anterior crowding, a little bit of a deep overbite. Well, actually quite a bit of a deep overbite. Hence, can almost assume that's the reason for the headaches. Or it's locking her jaw in. So a lot of people with deep overbites, you can tell on a ceph too, it'll hold the mandible back. It kind of traps the mandible. And the mandible is pushed back, which is causing all the headache issues. And as soon as you straighten out the front teeth or you flare them a little bit, then all of a sudden this happens to the mandible. It moves all by itself. It's not trapped so much. Hence, it alleviates all the TMJ problems, okay? So here we have some anterior crowding, and she has a little bit of a deep overbite. Now here's a Schwartz appliance, and we like to show our mistakes. This one happens to have a labial bow on it. We don't do that anymore, especially when you're expanding, because if you think about it, you're gonna turn this arch, you're gonna widen the palate, and then the labial bow pushes on the teeth. I mean, you might want it to push on the teeth a little bit, but typically, no. We don't usually make a Schwartz appliance with this labial bow anymore. If you look at this slide, as you can see, look at it sitting right on top of the lateral as we've expanded. So you either have to adjust this labial bow constantly or just cut it right off. Or better yet, we should have not made it like that in the first place, okay? So here she is, she's nicely expanded, however, and now she was, pre-treatment, she has a narrow arch in here, but she's still got crooked front teeth, okay? Her teeth are still crooked, narrow arch, wide arch, feels better. So what do? We put on, right here, you can see it. We put the little sectional on. So remember, phase 1 treatment, expansion sectional, and we put the braces on. And I think I mentioned this earlier before, using your Dremel to reduce the acrylic. This is the most important part. We did some transverse arch development. However, now we want to straighten the teeth, but if the acrylic is butt up against these crooked teeth, how are the teeth going to move? The wire is trying to straighten them, and the acrylic's preventing that from happening. So you have a Dremel that's chair side. Dr. Ronda would come in and zip this off and zip this off. And see here, like it would be hard to move. Now you've freed up the teeth for some beautiful movement as you're holding with your Schwartz appliance at the same time. So we place brackets on the upper front teeth, and in 1 month, from here to here in 1 month, they're pretty much aligned, the centrals. As long as you put the brackets in the right spot and you put the right bracket on the right tooth, you're laughing. And then once they're straight, there's some gaps still, then we put a power chain. So a power chain is those, instead of having single ties, we call these safety ties, single ties. This is a power chain. You can see that it's all attached in one unit, okay? And we put it on the mesial tie wing and the mesial tie wing of that bracket. So when you put a power chain on, there should be a single tie here and a single tie here. Each bracket has a mesial and a distal tie wing. because you want to prevent if you go around the last teeth, you could rotate the teeth if you put your power chain all the way around to the distal. So we go mesial of this tooth to mesial of this tooth. So again, you're going to learn a lot more about that. And here's what it looks like. The arch is nicely expanded in 7 months. The front teeth are aligned. There you can see what I was talking about, the single tie on the distal tie wing and the power chain to the mesial. If you go all the way around, it might rotate the tooth this way. So she's a very happy patient. She has beautiful straight teeth, and her mom loves her. Now, her mom's teeth are a little mess there, but we did a great job on her as well, and she looks amazing.